Again, everyone, welcome to the Orlando GI Journal Club. This is July 3rd, 2024. This is 7 a.m. in Orlando, Florida. We have two excellent randomized trials to review today. First is a randomized trial by Steinbruch et al., published in Gastroenterology. This is regarding comparing endoscopic mucosal resection using hot and cold snares and EMR or endoscopic mucosal resection using hot snare is the standard of care therapy for large non-pedunculated colorectal polyps, at least 2 centimeters in size. The reported adverse event rates with hot snare EMR are perforation in the range of 0.9 to 2.7%, post-procedural bleeding 6.2 to 7%, and post-polypectomy syndrome, which is 5%. There have been some smaller studies which show that cold snare EMR may be potentially easier and safer, but we have no evidence thus far for randomized trials. And so these authors performed a randomized trial to compare cold snare EMR and hot snare EMR of non-pedunculated polyps 2 centimeters or greater in size. This was a multi-center randomized trial based in Germany involving 9 tertiary referral centers. 396 colorectal polyps, at least 2 centimeters in size, were randomized to either hot snare EMR or cold snare EMR in a 1-to-1 ratio. Cold snare EMR is just as it's described. This is when electrical cautery is not used at all for piecemeal resection of the polyp. The follow-up colonoscopy was performed at 4 months, and the primary outcome measure was the rate of major adverse events, including intra or post-procedural perforation and post-endoscopic bleeding. So again, a total of 396 polyps in 363 patients were randomized. 193 polyps to cold snare EMR and 203 polyps to hot snare EMR. If you look at the ASA grade, the majority of patients were ASA class 1 or 2, and a small minority, 6.6%, were ASA class 3. The majority of the polyps were right-sided, with 27.5% of the polyps in the cecum and 41.7% in the ascending colon. In terms of the Paris classification, there was a 1.5% of the polyps had the 2A plus 2C classification, which means there is a central depression. The majority were 2A Paris classification, which is when it's flat. 8.3% was 1S, which is sessile. Now, next is in terms of their lateral spreading appearance of these polyps. The majority of patients were granular type and homogeneous. 31%, 22% were granular type, nodular mixed. And a smaller proportion of patients were non-granular type, which was around 20% of the polyps. If you look at the histology of these polyps after resection, adenoma was seen in 2%, adenocarcinoma within the adenoma was seen in 2% of the resected lesions. So this is the primary outcome in an intention to treat analysis. This means that the analysis is performed with the patients included in the original assigned group, regardless of whether crossover happened. And if you look at the rate of major adverse events, it was 1% in the cold snare group, 7.9% in the hot snare group, with p-value of 0.001. If you look at the types of major adverse events making up the total rate, if you look at the cold snare EMR group, there was no perforation, 1% of post-procedural bleeding, 14% intra-procedural bleeding, and 3.1% of post-polypectomy syndrome. If you look at HOTSNA EMR group, perforation rate was 3.9%, with post-procedure bleeding rate 4.4%. Intra-procedural bleeding occurred in 22.7%. However, if you look at the presence of residual or recurrent adenoma at the first follow-up colonoscopy, the rate was unfortunately significantly higher in the HOTSNA EMR group at 23.7% versus 13.8% in the HOTSNA group, with p-value of 0.02. The limitation of this study is that standardization of MR technique is difficult due to various options of therapeutic and prophylactic measures available across all the centers. And obviously the endoscopist performing the procedure is unable to be blinded to the group allocation. So in conclusion, cold stare EMR of large non-pedunculated polyps, 2 centimeters or greater in size, was safer than HOTSNA EMR. However, this must be balanced against the high rate of residual adenoma with cold stare. Next is a randomized trial looking at use of extracorporeal shock wave lithotripsy and endoscopy for treatment of pain in chronic pancreatitis. This was a sham-controlled randomized trial published in the Annals of Internal Medicine. Pain is a significant symptom in chronic pancreatitis and is often associated with pancreatic duct obstruction due to pancreatic duct stones or strictures. Endoscopic interventions, often in combination with ESWL, aim to alleviate pain in chronic pancreatitis by decompressing the pancreatic duct. The aim of this study was to assess the pain-relieving effect and safety of pancreatic duct decompression using ESWL and ERCP, compared with sham procedure, where an ERCP is not performed at all. Next, so this was a randomized trial, which was sham-controlled, performed at a single center in India with a 24-week follow-up. 106 patients with chronic calcific pancreatitis with intraductal stones were randomized to either ESWL with ERCP, where pancreatic duct stones are fragmented using ESWL, followed by ERCP for removal of stone fragments the day after ESWL. The patients were randomized to the sham group, where they performed a sham ESWL, where ESWL is not performed at all, and then a sham ERCP procedure, where the duodenum was intubated with a gastroscope without contact with papillary region or pancreatic duct interventions. The primary outcome measure was pain relief on visual analog scale at 12-week follow-up. So 52 patients were randomized to ESWL, 54 patients were randomized to sham. If you look at the mean age, it was 37 in the ESWL group, 38 in the sham group. The cause of pancreatitis was idiopathic in more than half of these cases. Smokers accounted for 25% of the patients in ESWL, 17% in the sham group. About 40% of the patients had diabetes. Strong opioid pain medications were being taken by about 50% of the enrolled patients. The mean pancreatic duct diameter was 8 millimeters in the ESWL group, 7.5 millimeters in the sham group. And the majority of patients had multiple stones, 60% in ESWL, 61% in the sham group. In terms of the size of the largest stone, it was 9.8 millimeters, mean 3.8 millimeters standard deviation in the ESWL, 10.5 millimeters in the sham group. So this is the primary endpoint. So they're looking at the intensity of pain using the VSA scale. And if you look at the baseline pain scores, the VSA pain scale ranges from 0 to 10, where 10 is the worst pain imaginable. 0 is no pain at all. Then at baseline in the ESWL, the mean pain score was 5.6, and in the sham it was 5.7. Now at 12-week follow-up, the mean weekly pain score was 0.6 in the ESWL, 1.5 in the sham group. And if you look at the mean difference, it does appear to be significant, with mean difference of minus 0.7, with 95% confidence interval ranging from minus 1.3 to 0. At 24 weeks, the mean pain score was 0.4 in the ESWL group, 1.3 in the sham group, and the mean difference in change was minus 0.8. But this crosses over 0, and so at 24-week follow-up, this difference does not appear to be statistically significant. They also looked at pain using other pain scoring measuring tools, such as brief pain inventory. And if you look at the pain differences, there does appear to be a significant difference in the pain scale between ESWL and sham. If you look at the mean difference in change, it's minus 1.5, with 95% confidence intervals, minus 2.3 to minus 0.7 at 12 weeks. And then at 24 weeks, it's minus 1.2, with a 95% confidence interval of minus 2.1 to minus 0.2. They also looked at quality of life using the QLQC30 questionnaire. And we need to just focus on, it's just the mean difference in change. And if you look at a lot of these scores, when they're at face value, it may look that it may be better for ESWL compared to sham. If you look at the mean difference in change with the confidence intervals, actually a lot of it spans 0, and so there doesn't seem to be quite an impressive improvement in their quality of life compared to the pain scores, which seem to be more impressive in their outcomes. Next is the summary of the secondary endpoints at 12 and 24 weeks. This is just a different way that the authors have presented their pain response scores. So they looked at responders to intervention, and they found that responders to intervention was 98% in the ESWL group, 91% in the sham group, and at 24 weeks, 98% in ESWL and 91% in sham. If you look at the kind of other measures of pain and activities and mood, again, if you look at follow-up at 12-week with the median pain-free days, it was 58 days in ESWL and 42 in sham. And mean days using opioids, again, it was lower at 4.6 in ESWL, 10 in sham. And this does appear to be statistically significant. And again, if you look at other measures, the only thing that really lights up is depression, with 17% reporting depression-like symptoms at the follow-up in ESWL compared to 35% in the sham group, with the mean group difference of minus 18%, with 95% confidence interval of minus 32 to minus 2. Next, when looking at the adverse events, the post-procedural acute pancreatitis rate was 6% in ESWL and surprisingly 2% in the sham group. Now, this is very interesting considering in the sham group, patient had absolutely no ERCP and no intervention was conducted within or around the papilla. So I wonder if this could be just spontaneous acute pancreatitis just from pancreatic ductal obstruction. They encountered no other adverse events, including perforation, infection, and post-sphincterotomy bleeding. The limitation of this study is that a pain diary is used for follow-up, which measured only the intensity of pain. This is conducted at a high-volume specialized single center in India, which limits generalizability, and also the availability of ESWL is limited. The average pain score was around 5 at baseline for both groups, and therefore the findings may not be extrapolatable to patients with more severe pain. And also the total follow-up of 24 weeks is relatively short. So the take-home point is that compared with sham procedure, pancreatic ductal clearance using combined ESWL with ERCP provided modest short-term pain relief in patients with chronic pancreatitis and intraductal stones. So for a recap, cold snare EMR of large non-pedunculated polyps was safer than hot snare EMR with an almost complete elimination of major adverse events. However, this must be balanced against higher rate of residual adenoma with cold snare EMR. Compared with sham procedures, pancreatic ductal clearance using combined ESWL with ERCP provided modest short-term pain relief in patients with chronic pancreatitis and intraductal stones. Thank you. This concludes this month's Journal Club. It's a little short this month. I hope everyone has a wonderful July, and if you're going on vacation, please have a wonderful time. I will see you back on August 7th, 2024, which is the first Wednesday of August. Again, just a quick reminder to everybody, we have Florida Live Endoscopy in Orlando, Florida, on August 22nd to 24th, 2024. It's going to be a wonderful conference with top endoscopists from around the world teaching us wonderful things about all things endoscopy. So please do join us if you can. All right, thank you so much. Please have a wonderful month, and I will see you in August. Thank you.